Okay, we have 20 minutes. Okay. Good. So we define infertility as a failure to conceive after 1 year of proper trial. This is extremely important. Many people live in different cities. Many couples live in different cities. They meet their wife maybe once a month, if they're lucky. And many will meet their wife maybe once every 6 months to 1 year. And they'll come complaining of infertility. So if they haven't had a proper trial with properly having intercourse for an entire year, we cannot label them as being an infertile couple. About 10 to 15% of people or of couples are infertile. You got to remember that there are some male factors and there are some female factors. And then about 20% of the time, there are combined factors. So it's very important to evaluate both the man and the woman at the same time to look for fertility. Can you excuse me for 2 minutes? So we're talking about the contributors to infertility. You need to evaluate both the man and the woman. And in our society, although things are changing, the man is usually the last one to get evaluated. And that causes unnecessary waste of time for the couple, unnecessary anxiety, sometimes unnecessary problems with them continuing their marriage. It's a very common problem, as you can see. Even in countries like the US, not many men will get evaluated as early as they need to be. These are what we usually hear people talk about. It's not the man's problem. We all just aren't geared or aren't interested in male infertility patients, and both are not true. So Evaluation requires basic history, physical examination. Then you do a semen analysis, a hormone profile, and other tests such as an ultrasound. And then you need to see whether they have a reversible cause of their disease that requires surgery or medication, or an irreversible cause of disease for which you go to assisted reproductive technologies. The anatomy of the reproductive organs in a man should know about. The sperm cells are produced in the testis, they mature in the epididymis, and the journey takes about between 80 days or so to reach the ejaculatory duct. 70 days within the testis and 14 days within the epididymis. So a total of 84 days. History. So why do you think Arnold here would be infertile? Is that the only reason? Exactly. So all the above can be reasons why he would have infertility. So what is this trying to tell you? It's trying to tell you you have to take a proper history. Okay, you can't just assume that you find one thing wrong. Every one of these can be a cause. The duration of the infertility, whether it's primary or secondary, is it the same wife or a different wife, previous evaluations, previous treatments, and family history. You need to get a proper sexual history about the potency, use of lubricants, which can cause sometimes spermicidal agents to be involved in it, and this causes sperms to die. Frequency of intercourse and timing of intercourse. Timing of intercourse pertains to the ovarian cycle of the wife. Childhood and development, you need to ask about a history of undescended testis because these are associated with infertility. History of previous bladder reconstruction, history of testicular torsions, traumas, onset of puberty. Patients who have delayed onset of puberty may have an underlying cause. Cystic fibrosis is also another disease, although it's of the lungs, can have some implications in terms of congenital absence of the vas deferens. Medical history includes systemic illnesses such as kidney failure, liver failure, previous chemotherapy or radiation therapy can implicate. And we've seen this so many times. This is such a sad thing. And this is again on the intersection of oncology and infertility. We did a study about 10 years ago looking at the knowledge, attitudes, and practices of oncologists referring their young men for sperm banking before getting chemotherapy. Many men will survive leukemia, will survive lymphoma. They will be too distracted in their younger life, and their parents will be too distracted, and they just want them to survive. But once they've gotten their chemotherapy, and 4 years later, 10 years later, they've survived. Now they want to build a family. They can't because the chemotherapy has burned their testicles, right? And because their doctor was not knowledgeable enough to say, before I start your treatment, why don't you go and bank, freeze some sperm? And these numbers were very low about 10 years ago. They're getting better, but they're still not 100%. And I think every man who's going for chemotherapy, every young man going for chemotherapy should be offered sperm banking or sperm freezing. Previous infections such as STDs, mumps of the testis can also affect the testicular function permanently. Previous surgeries, prostate surgery for sure, retroperitoneal surgeries that may cause anejaculation or retrograde ejaculation, pelvic injuries, and previous hernia repairs can all cause obstructive damage to the genitourinary tract. Toxins, we've talked about them. The common ones are chemotherapy, radiation therapy, alcohol abuse, marijuana abuse, anabolic steroids, pesticides have all been implicated. Even hot baths have been implicated. Physical examination, again, look for signs of steroid use in a patient. Look for signs of Klinefelter's, Noonan syndrome. Examine the testicles, make sure the proper size and location. Gynecomastia is a thing to look at for people with hormonal abnormalities. Previous abdominal scars, incisions can be clues, even if the patient doesn't know what they had done. Sometimes you can pick up the clue by finding these scars. Patients who are quadriplegics or who have nervous problems can also give you an idea about having ejaculatory issues. Penile anatomy, testicular size and consistencies. Congenital absence of the vas difference is a disease that we see in 1 to 2 in 1,000, 2 in 1,000 can be picked up. The most common thing you have to look for is varicocele, because varicocele is very common, and not only is it very common, it's a reversible cause of infertility. Position of the meatus, this is a epispadias or hypospadias, can cause the man to ejaculate, but not deliver the sperm into the cervical area near the vagina. You can measure the testicular size by physical examination or by ultrasound if you need to. Varicoceles. Varicoceles are very common. They happen about 15% of the normal general population, but they happen in about 1/3 of people with infertility or men with infertility. So they're a very common finding, and it's something that you have to look for because it's easy to treat. We talked about cystic fibrosis earlier because it is associated with congenital absence of the vas difference. Lab tests. Well, we need to do at least 2 semen analyses. They have to be at least 3 days or more from the date of having intercourse. Before that, we can do a hormone profile. That includes checking the testosterone levels, prolactin levels, the LH and FSH. And what is considered normal in terms of semen analysis has been broken down by many WHO criteria. It keeps on changing every 10 years. But you have to look essentially at the normal parameters, which terms of the amount of semen between 0.5 and 5, taqriban. Sperm count or concentration has to be above 15 million. It used to be 20 million. Forward movement of the sperm cells have to be about 25% in rapid movement or about 50% in rapid and slow movement. And normal morphology has to be above 4%. You don't need to know what these normal numbers are. But I just need you to know there's a reference range by the WHO that you can always look back to. If I give you on a test a sperm count of 0, you will know that that's normal. Abnormal. You will call that azoospermia, right? Okay. Poor morphology is called teratospermia. Low movement is called astenospermia. All right. So this was the old WHO recommendation. These numbers have changed, so forget these numbers. Semen analysis. Having a low sperm count doesn't mean you're infertile. It means you're subfertile. Okay. So the chances of getting pregnant are still there. They're just that much reduced. The relationship, again, the hormonal axis is very important to know. You have the pituitary gland, which regulates your LH and FSH production that give essentially the signal to the testes to produce the testosterone and to produce the sperm cells. And then we have negative feedback. If you form testosterone, you suppress the LH production. And if you produce the sperm, inhibin is produced, which will suppress the FSH production. So if you have a very high production of FSH in your bloodstream, that means your testis is not responding, right? That's an indirect signal that your problem is testicular. But if you have a very low FSH, it means the problem is a pituitary problem. And if you give more signal by giving exogenous hormones such as FSH, you'll produce more sperm. So again, you don't need to know these details, but you need to understand that there is multiple layers where you can have the origin of the problem. It could be pretesticular, it could be testicular, or it could be obstructive, post-testicular. FSH will initiate spermatogenesis, LH will cause androgen production, testosterone is responsible for secondary male characteristics, and to maintain spermatogenesis, prolactin can be elevated in someone with prolactin pituitary adenoma. very common to find people with hyperprolactinemia, and estradiol also provides negative feedback. So how can we treat male factor infertility? Well, we can't treat everything, but majority of men, after you evaluate them, you'll find will have varicocele, followed by idiopathic, followed by obstructive. Those in red or in pink can somehow be approached. The rest, not really. We'll talk about varicoceles. Varicocele is a dilatation of the venous plexus because of a deficiency within the valves within the veins. This causes bad blood to fall back in the testis, high temperature, and full of toxins. This will cause reduced testosterone synthesis, and altered cell membrane will be liable to thermal elevation of temperatures that come back from the abdomen to the testis. You can pick it up by physical examination, or you can pick it up by reversal of flow on the ultrasound. So this is a reversal of flow that you can see. This is the patient without Valsalva. This is the patient with Valsalva, and you can see that the red color demonstrates the reversal of flow within that bloodstream. And it's also a dilated vein. It's more than 2 millimeters in size. How do we treat it? By a surgical approach called a varicocelectomy. There are many ways of doing a varicocelectomy, but essentially the whole idea is you bring the cord up, you separate the veins in the somatic cord from the rest of the structures, and you ligate those veins. We know that even if you have a 97% chance of success in the varicocelectomy, only 71% of patients will actually have an improvement of the sperm parameters. And this will only result in pregnancy in about 40% of patients. So it's not guaranteed if you do the surgery that the wife is going to get pregnant, but it improves your chances. And the effect is not immediate. You need at least 9 months to start seeing the effect. It will not be complete for maybe sometimes up to a year. Obstruction is another thing that we can approach, sometimes by relieving the obstruction if it's technically feasible, and if it's not, then you have to obtain sperm by taking a biopsy from the testis, something called a TSA, testicular sperm aspiration, and giving it to the lab for IVF. Characteristically, patient with obstruction will have low volume, low motility, full epididymis with normal testicular sperm production. And how do we know it's normal? When you take a biopsy from the testis, it will have a high amount. You may have azoospermia on the semen count, but if you take a biopsy, it will have normal function. This means there's an obstruction. Vasectomy is something not very common in our part of the world, but it's gaining in popularity. And in the West, many men come to reverse their vasectomy. And even if you recanalize an obstructed vas difference, that does not necessarily mean that the testis will start producing normal sperm and go back to normal function. This is a microsurgical vasovasostomy with about 15 times magnification. And this is the suturing process where we can reconnect the two ends of the obstruction together. Patency rate is 95%, but you can see pregnancy rate is only 50%. That's why we advise most men, if you decide to do a vasectomy, you have to understand that you are going for what we call an irreversible procedure. Even if we can reverse the anatomy, doesn't necessarily mean you're going to end up actually getting conception. Another area of obstruction because of STDs or recurrent infections is epididymal obstruction. And the way we can cure this is with what's called a epididymal vasostomy, where we connect the epididymis to the vas difference with a side anastomosis. Patency rate is not as successful, and pregnancy rate is even worse. Majority of these patients can say, listen, I don't want to undergo the hassle. Just do a biopsy, get some viable sperm out of me from the testicle, give it to the IVF lab, and let's do some IVF and bypass the whole problem. This is a very popular approach, and the involvement of the urologist is just to obtain the viable sperm, and the rest can be done in the lab. The woman, of course, needs to have be involved. In fact, the burden is mostly on the woman. So our take-home message is male factor infertility is a very common contributor to couples' infertility. The man does need to get evaluated. It's not difficult to evaluate the man with infertility. Straightforward history, physical exam, and minor lab test and radiological test. Treatments are available for reversible infertility, such as obstructive infertility and varicocele. Those that are not reversible, we can help them by obtaining some viable sperm for assisted reproduction, such as IVF or ICSI. Now, if the man is infertile and they have a genetic defect and you decide to go to ICSI or IVF, you will pass down these genetic defects to the offsprings. And it's usually a multimodality, multidisciplinary type approach to these things where we work very closely with the gynecologist and with the IVF lab to help these patients out with their outcomes. Okay, any questions? Sorry, we ran through this. I know it's a lot of content, but then again, I don't expect you to become experts in the field. Just know the basic important concepts of it. Understand that there is a reversible cause and some irreversible causes of male fertility. Just remember that there's pre-testicular, testicular, and post-testicular causes of infertility. Allah yafikum. Okay, thank you. Good luck. Yeah.